Hello everyone, this is Elizabeth Muli from the Technical University of Kenya, presenting a paper on eSurveillance for investigating capacity of health systems to detect and control infectious diseases of poverty, a case of Kitui South Sub-County. We worked on this with my collaborators, and we have Francis Makoha from Mount Kenya University, Dismas Lusiti from Technical University of Kenya, Carol Hunja from Southeastern Kenya University. We start with the introduction. As we know, globally, the enhancement of health systems to overcome the challenges posed by infectious diseases remains a priority. Good health and well-being is a third goal of Sustainable Development Goals to ensure a healthy population with access to affordable and equitable healthcare. This, in turn, improves the quality of life, alleviates poverty levels due to improved productivity, minimized cost on treatment, and also reduction of time taken seeking treatment by patients and caregivers, and all in all, minimize of transportation costs to medical facilities. The Kenyan Constitution also provides that every person has the right to the highest attainable standard of health. The country, Kenya, also recognizes the need to reduce inequitable distribution of health facilities, more so in impoverished regions. Issues such as understaffing, inadequate laboratory equipment, hinders effective diagnosis to these diseases and infections. Also, poor infrastructure, among others, impede to the desired goals. Also, all these factors combined contribute to a high burden of diseases of poverty, and hence the need to investigate the capacity of the county's health systems and develop mechanisms for monitoring of the needs of these health facilities. The motivation and problem area. Kitui County registers poverty levels of approximately 40%, and the available health facilities are sparsely distributed, making their access to the locals very difficult. Existing systems of record keeping are mostly manual, and this hinders timely and informed decision making. Understaffing, inadequate laboratory equipment for effective diagnosis of infectious diseases are also very common. There is the need to investigate the capacity of these counties' health systems to report infectious diseases of poverty and pandemics so as to ensure rapid response. So this informed this research to develop a web-based surveillance system where data can be accessed in real time and analytics done to generate the required reports for timely decision making. Research objectives. The first one was to investigate the capacity of the health facilities in Kitui South Sub-County to effectively diagnose and treat infectious diseases of poverty. Second one was to design and develop a web-based surveillance system with all the findings to ensure monitoring and surveillance of the health facilities by the Ministry of Health and the county government officials is possible. We also did geospatial mapping of existing health facilities in the sub-county to assess their accessibility to the locals. We also did analytics and generated various analytics reports which can be used for decision making. The research approach and methodology we used. This study used descriptive survey, and information was collected mainly in the health facilities across Kitui South Sub-County. The target population was mainly medical personnel in these facilities. So during this study, researchers visited all the health facilities in Kitui South Sub-County, and the following medical personnel were interviewed: medical doctors, clinical officers, nurses, laboratory technicians, and pharmaceutical technologists. We employed qualitative approach comprised of key informant interviews and observations using checklists. The interview questions and schedules were prepared, and thereafter the data collection exercise kicked off. The technology that we used to implement this intervention, we developed a web-based surveillance system and hosted, and then also a mobile application with offline features to enable the collection and sharing of information even without access to internet. So this we realized when we visited the facilities, because some of them had challenges when it came to power and also poor network connectivity. So we did an extension of the web-based application in form of a mobile application with offline features to enable the data collection. This application was used mainly by the public health officers to collect data using tablets configured with the mobile application from these health facilities during their inspection visits. And because of the challenges we just mentioned, the power outages and poor network connectivities in some of the facilities, the public health officers would later synchronize the update of the collected data when they get access to the internet. And this was normally done mostly at the level 4 hospitals, where the public health officers are based and power and network connectivities is a bit reliable. So through this intervention, we are able to ensure sustainability and use of this application to ensure efficient management of health records and generation of reports for timely decision making. Findings of the study. We start with health facility levels and their medical personnel. A total of 51 health facilities in Kitui South Sub-County were visited, comprising of government hospitals, private and mission or faith-based hospitals, and 5 of these facilities were newly opened and were not yet operational. Out of the remaining 46 facilities, 4 were level 4 government hospitals, 8 were level 3 health centers owned by the government, and 4 were level 3B nursing homes, which were privately owned, and 30 dispensaries. So the data collected, we captured it in the system and we did analytics and generated several reports, and below is a table showing a sample of those reports. So this is on facility levels and their medical personnel. So as you can see, we have the levels of facilities, their numbers, and also the distribution of the health workers in these facilities. From this, we can see clearly that most medical doctors, actually all of them, were found in government hospitals, the level 4s. Their clinical officers were also found mostly in the health centers, which are level 3s and the level 4 government hospitals. But we only found 1 clinical officer in one of the dispensaries. So majority of the medical personnel were the nurses. At least each facility had nurses. And most of the dispensaries had at least 1 nurse who was mostly in charge. And at times, she was the only one who was attending to all the cases. And whatever they could not be able to attend to, they would refer to the higher level. Most of the dispensaries did not have functional labs, except one where we found a lab technician. And most of the lab technicians were found in the government level 4 hospitals, the health centers, and nursing homes. And pharmaceutical technologists were also concentrated mostly in the government level 4 hospitals, and just 2 in some of the health centers, and 1 in the nursing homes, and another 1 in the pharmaceutical, in the dispensaries. The public health officers were only found in the level 4 government hospitals where they are normally based. The other analytics that we did was on catchment population and the medical personnel in the health facilities. Most of these facilities are sparsely distributed, which makes them inaccessible by the locals. and they are spread across 6 wards in Kitui South Sub-County, namely Mutomo, Ikuda, Ikanga, Kansiko, Athi, and Muda. So the analysis below shows the number of medical personnel across all these facilities, and it can be used to inform the additional number of medics required as per the WHO recommendation based on the catchment population that they serve. So in the analysis below, we can see the wards in Kitui South Sub-County, then the catchment population that they are supposed to serve, the average daily population they serve, and the distribution of the health workers in these facilities. The other analytics we did was prevalence of infectious diseases, mostly in children. So respiratory tract infections recorded the highest with a total of 43 cases across all the visited health facilities. And as you can see, there is a graph showing all the other infections. RTIs, that is respiratory tract infections, recorded the highest, followed by diarrhea, skin conditions, intestinal worms, fungal skin infections. We also had some suspected cases of malaria, and all the others are shown in this graph. The other analytics we did was challenges faced by these facilities to effectively diagnose infectious diseases. Apart from understaffing, we also noticed that most of these facilities lack equipment. And the analysis below shows some of the top 20 laboratory equipment requirement needs by the health facilities. So most of them lacked microscopes, and the recommendation was LED microscopes. They also lacked centrifuge, incubators, HB machine, rotator, and most of them, especially the dispensaries, lacked functional lab. And this was very critical for them so that they could be able to at least diagnose and do several tests instead of referring almost all the cases. Then with those analyses, we come to conclusion and outlook. So with the universal healthcare as one of the social pillars of the Kenya Vision 2030, there is a need to adopt modern technologies for collecting, storage, and dissemination of health information for easy access by all the stakeholders in the health sector. The web-based surveillance system will provide a platform where all the stakeholders can access up-to-date information on existing facilities for informed decision-making regarding funding, staffing, and resource allocation. The geospatial distribution maps of existing facilities are very crucial in identifying areas with inadequate health facilities and also helping in planning of equitable distribution of new facilities to ensure accessibility by the locals. So in the final paper, we have sample maps of the geospatial distribution that we did. Another outlook, since the government has put in place key policies and necessary strategies to promote uptake of technology in health, this study recommends adoption of technology in the health sector to leverage on the benefits of ICT to the fullest in improving access and provision of healthcare to all. And we strongly believe that this intervention can be scaled up to cover the whole county, and when it succeeds, it can form a model to be replicated in all the other counties in Kenya. Thank you.